You lost the meeting.
Welcome, everyone. As we wait for people to join, please go ahead and introduce yourself and where you're joining us from in the chat.
Thank you very much. This is
Okay, we can go ahead and get started. So good morning, good afternoon, and good evening from wherever you're joining us from. My name is Kokar, associate on the Boost team, and on behalf of Boost, a warm welcome to our Bright Spot series, co-hosted with the Selena Center for International Development and Research based in Nigeria. This session is part of a three-part series, Northern Nigeria State's Routine Immunization Strengthening Program, building capacity of primary healthcare managers at state and sub-state levels, approach and lessons. Next slide, please. This session aims to disseminate and showcase learnings from the implementation of CDAR's innovative capacity building approach across the MOU states. We hope by the end of the session, you will gain an understanding of CDAR's innovative capacity building framework and gain insights into the success and challenges from diverse capacity building interventions implemented at the state and sub-state levels. Now would be a great time to please go ahead and introduce your name and where you're joining us from in the chat. And before we get started, I'd like to go over a few housekeeping slides. So during today's session, you'll hear from our three presenters on the significance of capacity building approaches. Afterwards, we'll break into a panel discussion with our guest speakers to discuss capacity building in their own context and have time for Q&A at the end. During today's session, please stay muted to limit background noise. If you'd like to speak, you can always raise your hand or put your questions or thoughts in the chat. Next slide. Sorry, next slide, please. Please also note, Boost does not permit the use of artificial intelligence tools during our webinars or course sessions. Today's session will be recorded and slides will also be available by the end of the week on our Bright Spots Boost Learning group, as well as emailed to you with the email you used to register for the session. If you're able to attend all three sessions of this series and fill out all post-session surveys, you'll be awarded a certificate of attendance by Boost and CDAR. Finally, this series is only offered in English. However, we hope to have more multilingual content soon. Next slide. For those of us who are joining for the first time, the Boost community is a diverse network of more than 4,500 immunization professionals from 156 countries. Through our online platform, boostcommunity.org, we offer opportunities to our community to connect with fellow immunization peers and experts, learn skills that build capacity and advance careers, and lead immunization programs in any circumstance by sharing best practices and lessons learned through sessions like these. To access today's recordings and slides, we encourage you to sign up for the Boost platform and join the Bright Spots Learning Group. Next slide. For those that are new to the Bright Spots series, Bright Spots are stories that shed a light on the work that is happening on the ground and inspire immunization professionals to learn, adapt, and take action in their own communities. From engaging with religious leaders to improving supply chain to reach the last mile, there is innovation occurring at all levels of the system. To date, we have published more than 60 Bright Spots from 27 countries, which you can check out at brightspots.boostcommunity.org. Next slide. I'd also like to introduce everyone to the CDAR team who is co-hosting the series with us on capacity building today and in 2 weeks on demand generation. Next slide. I'd also like to welcome our guest speakers who you will hear from not only during the presentations, but during our panel discussion where they will share capacity building in their own context. Next slide. I'd like to welcome our first speaker, Jenny, to tell us more about the significance of capacity building and continuous learning for healthcare providers. So over to you.
Thank you, Aisha.
It's really great to see people joining from Nigeria, Ethiopia, Pakistan, Bangladesh, Cameroon, Sudan, Angola, Ghana, elsewhere. So welcome. Today, we're going to be talking about the significance of capacity development and continuous learning for health workers. But I think it's really important to say this is in the broader context of working also in comprehensive ways with improving organizational structures within a health system, and also working specifically with leaders and managers to address some of the root issues in the environment and sort of the background context. So I just wanted to highlight that the pandemic really, I think, emphasized the need for adaptive and continuous learning systems. And the approach that we're going to talk about today talks a little bit to that, but also about making sure that you're paying particular attention to the health workers and that working environment. So the effort that we're talking about today was over 10 years. It was a joint collaboration between the governments in 6 states in northern Nigeria, as well as Gates Foundation, the Aliko Dangote Foundation, and partners like CEDAR. And some of the things that really were driven home was the importance of looking at the gaps that are the most significant, looking at the Pareto principle of what are your biggest challenges in a health system. And a lot of studies, especially in sub-Saharan Africa, point to a large portion, sometimes over a third of your challenges relating to health worker capacity. And so there's a nice article here. When you get the presentation, it'll be the link will be there. It'll be good to peruse that article. But it really nicely highlights how much of this challenge is in the health system's challenges are in health worker capacity. And there's 2 broad categorizations that get pointed out when it comes to the health worker gaps, capacity gaps. One is around knowledge and skill disparities, and the other one is around staffing inadequacies. And we know that some of those staffing inadequacies relate to the frequent turnover of staff, the ways that some of the locations, the urban locations get overstaffed and the rural locations understaffed. So some of it is around distribution, some of it is around actual insufficient numbers of personnel. So next slide. The continuous learning aspect was really important to what we did over the course of the 10 years in these 6 states. And I just wanted to highlight Gavi's current learning system approach, because I think it nicely highlights the importance of a continuous learning system. And this is what Gavi is striving to do with its current 5.0 strategy, where it's looking at the design, the prioritization of evidence, the generation of evidence, and then the timely use of learning and evidence, all in the context of continuous learning systems. So just wanted to bring out that point and how the work connects to Gavi's broader efforts around some of these system changes. Next slide. So the exploration that we're going to be looking at today really tries to get to these root issues or the underlying factors contributing to the capacity gaps. And we noted that there's 2 main ones, the knowledge and skill disparities, as well as the staffing inadequacies. So if you look at the high level issues, when you look at these capacity gaps, part of it relates to pre-service, where the curriculums are many times outdated, don't reflect current knowledge and best practices. We also look at some of the poorly targeted training and supervision that many times is cascaded or just goes into an automated mode with checklists, and the focus ends up being on completing the tasks rather than on learning and improving. And I think that's a really important thing that you'll hear about today, where some of those system changes we're trying to address organizational ways to get away from some of those focuses on just the task completion. There's also many challenges with limited resources. Learning materials, competent mentors within the system, and also I would say peer learning networks. Within staffing inadequacies, there's of course a challenge related to rapidly growing populations. I think many of your own countries have this challenge. Skilled health workers migrating, so the brain drain, and then the tendency, of course, that I mentioned before, and I'm sure this is in many other situations, to have the concentration of health workers in urban rather than the rural and remote areas. So let's go to the next slide. And I'll wrap up the overview before we go into the details. So this really talks about some of the things Sorry, can we go to the next slide? Thank you. This talks about some of the key enablers that try to bridge the knowledge and skill disparities in the health system. And I want to again reiterate that these are never in the context of only doing capacity development and continuous learning with health workers, but also in that much broader context of building health structures and improving health structures that can improve how health workers learn and are motivated, and simultaneously working on strengthening the capacities of the leaders and managers in the health system. So today you'll hear about some of the culture of transparency issues around the work environment, things that we're working on to lead to clear lines of communication and accountability, things that focused on regular monitoring mechanisms to track the program performance, some of the feedback loops, mechanisms for evaluation and learning. So really trying to look at how do government health systems learn? How do they look at this continuous cycle of improving? The regular performance feedback and recognition of individual contributions to support that motivating work environment. And this links to improving some of the existing structures like quarterly review meetings, supportive supervision, annual planning. And then finally, really making sure that there's an investment in resources and tools that have a specific focus on skill development and facilitating knowledge retention. So this is a broad overview, and now I'm going to hand over to Amina, and she'll go into some of the details, and we'll have others go even further into details. Thank you.
Thank you so much, Jenny. Hello, everyone. Thanks for laying or clarifying the importance of capacity building for health workers and its impact on health outcomes. I think on the NRIPS project, with support from the Bill and Melinda Gates Foundation, but also in collaboration with the states, one of the first things that we did to understand the gaps with knowledge and skill across the states was a robust diagnostics to actually identify what categories of skill gaps we had in the states. And on the next slide, you see the result of that. So we found that there were three broad categorization of knowledge and skill gaps. The first being institutional gaps, which are deficiencies around organizational structures and policies. Specifically, what we found was there was suboptimal adherence to organizational structures, reporting lines, and so this caused some disruptions in how teams communicated and ultimately affected work. But there was also poor domestication of policies, including the PHC under one roof, which is a national policy that seeks to reduce fragmentation of PHC program governance in states. On the programmatic side, we found deficiencies with design, implementation, and evaluation of health programs. Specifically, we found that there weren't a lot of tools or SOPs or job aids that clarified how processes should be carried out to guide the implementation of certain program processes, whether it be microplan development, annual work plan development, etc. We also found that there was an absence of monitoring and evaluation dashboards. So beyond what was available through, say, DHIS2 and those kinds of administrative platforms, we didn't have a lot of visibility into, for example, supply chain activities or financing activities in the state, how funds were dispersed or was retired on a health facility level, case-by-case basis. And on the individual side, we found deficiencies with individuals being unable to perform their roles and responsibilities effectively and efficiently. And this was as a result of poor implementation of targeted training. So what we saw is people just come to the states with their own training plan, not necessarily trying to key into what exactly states teams needed specifically and trying to build that. And providing mentoring where needed. A lot of the training were also in-class situations where you do like the theoretical teaching without the follow-on for, say, on-the-job training, where we know you're able to then support, essentially be their guide as they go about their daily work and implementing. We also found an absence of continuous and sustainable skill development structure. So there wasn't a system that ensured that health workers at the states were able to continue to build capacity and continue to learn as things change within the health system. Understanding the problems was one step, and in collaboration with the states and also partners within the 6 states, we identified and implemented a number of interventions across these categories of gaps that we'll be seeing, yes, on this slide. For institutional gaps, one of the things that we did was providing technical support for full implementation of the PhD under one roof. If you recall, I said this is a policy that seeks to reduce fragmentation of PhD program governance. Specifically, we supported the revision of the governance structure, so clarifying what reporting lines were, what administration of PhD system versus coordination, things like working groups, and what the linkages should be across levels. We also supported with the development of an implementation of minimum service package, which is essentially a costed plan that highlights how the state intends to ensure full delivery of PhD services across its health facilities. Also at an institutional level, we supported with the establishment of dedicated human resource units within the administrative department of the primary healthcare boards. And this unit essentially then served as the focal point for all things capacity building. So essentially institutionalizing a unit that was responsible for ensuring continuous learning of the health workers at the state level. On the programmatic side, as we mentioned, there were a lot of gaps with the lack of tools, lack of clear laid down processes or SOPs. So what we did was developed a number of TORs, terms of reference, process management guides, things that clarified what exactly supportive supervision should be. So not, as Jenny highlighted, not just a matter of checking things off the list, but essentially what the process should be, the fact that there is a mentoring component, a problem-solving component of that should be happening at the health facility when state officers go to the health facility. We also clarified things like annual operational planning, making it a bottom-up process, not something that happens strictly at the state level, but also getting input from LG and health facility to ensure that the plan is fully representative and inclusive of all of the levels of government and partners within the state. Beyond this, we also supported with developing and standardizing user-friendly tools and visualization of program performance. So things that, as I highlighted, a lot of the viz that was used for data was probably things around DHIS2, which is mainly focused around coverage. It has some other indicators, but primarily checks things like coverage at health facility, ward, LGA, and obviously state level. So we supported with things like developing, say, the direct vaccine delivery dashboard that helped you see per time the stock levels at health facilities. Also created a system that ensured health facilities were able to report stock levels and were able to make updates to these dashboards. We created finance management systems that ensured we're able to track on a health facility by health facility basis the use of funds, expenditure of funds, retirement of these funds. And at the state level, we're able to see this visually through these dashboards. On an institutional or an individual level, pardon me, we set up in-house capacity development and mentorship program. And here we leveraged the vast array of partners we have across the state. We created a mentor-mentee or coach-coachee relationship between partner organizations and state personnel that ensured that they were properly supported during their capacity building. So someone that they could go to ask questions if they had any challenges, someone that was on the ground to provide support as is needed for executing some task. And finally, to be able to track capacity gains on this project, that's on the individual capacity building, we developed monitoring and evaluation system that was essentially built on a novel 5-point rating scale that you're looking at the moment. We wanted to be able to track what progress meant for each of the program officers on the capacity building program, and figured that this 5-point rating scale was a way to be able to check and track capacity gains. And I'll walk you through what we came up with. The first level of this, essentially, the state personnel is unable to conduct the activity. So this is, in some cases, the stage that we met a lot of the state program officers, which is some of them don't know that this is a requirement, the particular task you're asking them to execute, be it some form of analysis or some problem solving to figure out certain solutions. And so this is a baseline level for some state program officers. The next level is then being able to conduct the activity with support. So having identified that this task is something that should be conducted with support from partner organizations or even a senior state personnel, the program officer is able to then execute the task that is required. The third level is then being able to conduct the activity, but with prompting. So this means even though the state program officer knows what needs to be done, also knows how to do it, there's still some gap in terms of ownership or responsibility to be able to take the initiative and execute said activity without being prompted. So to understand that it is your responsibility to provide this kinds of information was the third level. So the inability to do that made you a level 3 on the rating scale. And on level 4, these are individuals that are able to conduct the activities independently without prompting. So this is someone that knows what's supposed to do, doesn't require support with conducting said activity, doesn't require prompting, so is able to do the work fully. But we thought that it would be valid to add another level, which is why we have 5, the last, which is the activity being institutionalized. And what this means is the state personnel has been able to conduct the activity independently and has begun training a backstop that is able to take up this role if by chance he's out of office or anything. So this creates some form of continuity or sustainability for the capacity building project. Overall, we achieved some successes on the capacity building project. And as at 2022, when we left the states, that's the 6 states, on the institutional side, we had a 200% cumulative increase in PAT under one roof score, which with states having between 21 to 57% increase between 2015 and 2022. We also supported with the establishment or reactivation of the Human Resource and Training Unit within the administrative department, and also supported the development of TORs and operations guides for these units. And we supported with 100% of all of the states review of the administrative and coordination structures for routine immunization PAT service, PAT program coordination. On the programmatic side, with the aid of the tools and job aids we developed, we're able to support the development of 8 integrated annual program implementation plans. We're also able to help set up 42 technical working groups that were established and eventually expanded PAT because they were initially routine immunization working groups. And we supported with the development of at least 10 SOPs and guides across themes, so across themes of service delivery, supply chain, monitoring and evaluation, supported with development of a total of, say, 10 SOPs that would guide processes and institutionalize the right way of conducting these processes. On an individual level, we're able to have 100% of the program officers enrolled on the capacity building program and linked with mentors and coaches from partner organizations. And we cannot emphasize the importance of having that kind of integrated collaboration at the state where multiple partners come together to build capacity of the states. We also had on an individual level, 84% of program officers able to conduct their roles independently without support from coaches. And we had 77% of state program officers having their roles institutionalized. That is, they have backstops, able to conduct the activities in their absence, and a clear sustainability plan for at least a year. Overall, all of these successes laid the groundwork for delivery of quality PAT services. However, we found that in order to achieve successes on the ground, that's at implementation level, that's at health facility, at LJ level, was imperative to extend capacity development to these levels. That's replicate what we had done at state level, at LGA level, and hence the 1LG approach, which sought to see or to test what successes would look like if we replicated this kind of capacity building approach at LGA level. And my colleague from UB, Dr. Chiroma Umar, will be taking us quickly through that. Thank you very much.
Hello, should I go? Hello?
Yes, please, Dr. Chiroma, kindly go ahead.
Okay, so thank you very much, everybody. Allow me to give an insight of what happened in Yobe, the the plan for the state to have an approach that will increase capacity of workforce at the LGA level. I think let me start by giving the rationale behind that. We all know that in Yobe State, one of the few states in the northern Nigeria, which routine immunization has been very around single digits, and Damatru LGA is one of the LGAs that we feel we pilot this very important initiative, where at that time it's between just about 9.7% of the hepatitis coverage has been noticed in the LGAs, but at the end of it, we're able to have a substantially increase in number of children vaccinated. So quite a number of children are unvaccinated. So this warranted that. The second rationale is to find finding from the logistics review that intervention that have been implemented have effectively strengthened the capacity, both at the state and at the which catalyze at the LGA level, state and LGA level, with significant capacity of the LGA and facility managers, who are the actual front runners for the delivery of RI services, which at that time remain suboptimal. We all know that the tax rationale is to underscore the need for the targeted capacity building, program management, and problem solving at this critical level of enhanced and sustainable immunization services. We all know at that level of Yobe, that at the state level, we have the capacity, at the lower level, capacity. Objective of this initiative is to identify and implement specific interventions that lead to improve RI performance, especially in dermatology purposes. Second is to build the leadership and the management capacity, especially at the LGA level, and the facility managers where the conduct of the RI services is provided. And the third is to document whatever we learn from it, the intervention and approaches that can be scaled up to the LGAs for better performance across the state. The expected outcome is to improve performance across thematic areas and immunization uptake in the LGAs. The second expected outcome is to have an overall improvement in the core competencies of the LGA managers, especially at the management capacity level, that will help to sustain the program. The third is to detail the lesson learned that can be scaled up to the LGAs, similar LGAs, this kind of interventions. Next slide. There are we approach this in three strategic areas. One of which looking at the embedment of management partner, and the second we define performance indicators, and the third we establish accountability system. So looking at the component of embedment of management partner, we through the support of the partner that actually supports the state, ensuring that we focus the material for this intervention. And we also use the LGA and the team to conduct a baseline diagnosis across all the thematic areas, looking at the component of governance, financial management, service delivery, supply chain, community engagement, and monitoring and evaluation in the LGAs. And the last is to find finding from the assessment from the development of capacity improvement roadmap within the LGA. So with this, we're able to come up with. The next is to define performance indicators. We developed a monitoring framework which consists of useful targeted indicators that will track performance of routine immunization, which include the percentage of PSs with updated real microplan. And the second, percentage of plant outreach statement reached. In each facility has its facility catchment areas where they conduct outreach. So we look at total number vis-a-vis what has been conducted. The third is percentage of its facilities recorded stock out of vaccines. We know that vaccines is logistics stuff from the national, state, LGA, and the end users, which is the facility. We want to see how far the vaccine actually reaching the facility in adequate quantity that will warrant a better performance in terms of immunization. And the third, and the fourth is the parental, see the level of cohort of children that have been vaccinated. How many of them had the complete 3 rounds of Penta 3, and how many actually dropped out? And the last one to look at coordination component, the capacity of the LGAs to be able to manage the coordination properly by conducting proper meetings. How many meetings were they able to hold in a week or a month? And the last one, the data from this indicator, from this 10 RI providing facility in Damatu local government areas were analyzed and the report was shared to relevant stakeholders across state and NGOs and even the both partner and government partners. That will help to inform decisions for further improve activity performance. And the third establishment accountability framework, accountability system. We establish a high level by state and local government accountability framework by easing facilitating the ease of collaboration, provide opportunity for ownership, and also get strong support from government. And the second is we instituted the use of user-friendly performance dashboard, routinely track performance for be it LGA and the facility based on the outcome of indicators. The next is leveraging the use of mentors and also supervisors for on-the-job training, capacity on the LGA team and healthcare and health staff on routine review of the performance by the state team, routinely looking at both at the LGA and facility level. Together, we agreed on how this is going. And the result of it all has really shown to us as achievement. Next slide. The result of this intervention has really shows a high level of successes recorded in terms of the performance as well as the number of children vaccinated as well as the coordination level. So if you look at under the coordination level, hitherto the LGs having not understood their roles and what they're supposed to be discussing, how do they approach the conduct and the managerial capacity of the RI. Through this, we are able to have 50% of the NERIC meetings that has improved compared to time before these interventions. And of course, looking at the number of children in immunized, we are able to notice that over 56% of children were actually reaching 3 and other percent, just to show that there's a marker of improvement. So looking at also the availability of the vaccine stock out has been as low as the nationally accepted vaccine stock out level of 7%. And at the same time, the wastage, so much has been at the low level because of the capacity and understanding what to do with regard to users of vaccine during immunization. And also looking at the conduct and also our ability to see whether what we have agreed upon during the on-the-job training or this supervision or mentoring, some kind of action point are actually generated both at the LGS facility level. And we noticed that 95% of those activities or action points said to have been acts have been implemented by both the LGT and the period. So looking at also the Penta 3 dropout, the cohort of children that actually been vaccinated over the period, Penta 1, Penta 2, Penta 3, we noticed that the drop in terms of the dropout of the children, less than 10%, which is significant because of the national target, has so far been noticed. And lastly, we look at the capacity transfer. We all know in this part of the country, most of the knowledge, especially in Yobe in particular, knowledge are all stored at the states and very minimal at the LGS and even least in terms of capacity at the lower level. So we realized through this initiative, capacity has been transferred to the LGA team. They are now taking the lead in ensuring that they plan and execute routine immunization activities through the support of all mentors and supervisors at the LGA, by the LGH team. So I think next slide. Hello? So I think that's, thank you very much for listening. Over from me.
Great. Well, thank you so much to all of our speakers for sharing your insights with us. I'm excited to move on to the next section of the webinar, which will be the panel session. My name is Liz Colway, and I oversee Boost Community Engagement and Applied Learning at the Sabin Vaccine Institute, and I'll be moderating the panel session. I'm very excited to be joined by my esteemed colleagues. We have Jenny Sakura, who we heard from earlier in the presentation. She's a global immunization expert and learning consultant who has over 2 decades of experience in public health, including a focus on behavioral and human-centered approaches, routine immunization, and integrated primary healthcare in low resource settings. I'm also joined by Adamu Abdullahi, who's a deputy program manager of the State Emergency Routine Immunization Coordination Center in Bauchi State's Primary Healthcare Development Agency in Nigeria. He is a public health expert with over 15 years of experience in immunization and child health programming in Nigeria. And lastly, I'm joined by Sohini Sanyal. Sohini is a capacity building manager at John Snow India, who has 20 plus years of experience facilitating organizational training, including 5 years in the public health domain. And she currently supports more than 37,000 vaccinators in India, helping them to improve their skills and knowledge in immunization. So thank you all for joining us this morning or afternoon, wherever you're joining us from. And also just appreciate everyone who's been sharing comments and questions in the chat. I know some folks have been answering them, and we will have time after the panel to address all of your questions. So I think my first question is going to go to Jenny. So drawing from your experience as a learning specialist who's collaborated with the Bill and Melinda Gates Foundation and Gavi, the Vaccine Alliance, on capacity building and learning initiatives, how pivotal has capacity development been in realizing health outcomes within the programs that you've overseen? So over to you, Jenny.
Thank you, Liz. I think there's lots of language around capacity building and capacity development. That's been around for a long, long time. But when you look at the behaviors around how are those efforts actually done, a lot of them really are capacity filling rather than capacity building. And so I think it's really important to look under the hood to understand what are the interventions, how do they connect to that broader health system strengthening effort, and how do they connect to organizational structures in the health system and to improving the skills and abilities of managers and leaders. So they have to be connected to all of those different elements. So it's part of that complexity aware concept of if you just work on one small thing, you won't have that long-lasting impact. It'll just be sort of a relief model, not a real development model. Thanks.
Great, thanks so much, Jenny. My next question is for Adamu. So my question for you, as the Deputy Program Manager for the Bauchi State Primary Healthcare Development Agency, could you elaborate a little bit more on the Bauchi State experience of capacity building at subnational levels and any areas that you've identified for enhancement? So over to you.
Good afternoon, everyone, and thank you, Liz, for the opportunity. Yeah, so actually for Bauchi, the experience we had regarding the capacity building approach is yielding a very good result. If you look at the program officers, before we started this approach, most of the teams or most of the support that we need to sit for the national to give guidance on what to do. But when we started this approach, where a program officer is identified and is linked to a coach from the partner organizations who will mentor him on the specific tasks that he or she is expected to discharge, and that actually build the capacity of the health, our program officers. As it is now, most of the program officers in the state are able to discharge their responsibilities without support from any other person. Just for example, the planning and conduct of the RISS at the state and the LG level, the state is able to plan and make sure that the quality supportive which are being conducted, and be able to regularly analyze the data and see where the issues or the gaps are, or where the plan sessions are not properly conducted, so that they can follow up and see how they can improve on that one. So when you go, for example, we take a logistics, before this capacity building session, we have the third-party logisticians who usually deliver vaccine for us in the state. But with this capacity building, our logistics team are now able to conduct the state direct delivery to all our 323 equipped health facilities, where the unequipped would now come and pick as the casket. So capacity building actually is something that we need to strengthen, and is yielding a lot of result in improving the quality of services being provided. Some of the challenges we encountered is the issue of multiple tasks. Some of the program officers that were identified for the capacity building has other tasks apart from routine immunization to conduct. So also looking at the number that we need at the state, some of the program officers, they are backstop, actually are not that enough for them to be able to discharge their responsibilities. So some of the recommendations I will highlight here is the issue of ensuring that this capacity building approach went down to the local government as well as the health facilities. We all know that the state and the LGA, our main role is usually coordination, monitoring, and providing the guidance. The activity is conducted at the lower level. So I think we need to start thinking of how we can also build the capacity at the lower level, the local government, as well as the facility where these services have been rendered. Also, the chief executives, the program officers may have the capacity, but I think there is need for also to engage the executives, because sometimes whatever you need to do, you need to have their own support. So if they don't have the capacity and they don't understand what is intended to be done, sometimes even if you submit something for them to approve for implementation, you may have some hitches and some of the effects. So thank you very much, and this is what I can share.
Great, thanks so much, and appreciate you sharing both the challenges and some of the solutions that you're working on implementing. So moving on to Sohini, based on your experience, could you provide insights on how capacity building is enabling health workers to address challenges, especially in immunization and zero-dose implementation?
Thank you, Liz. It was great that Jenny talked about capacity building, capacity filling, and I think I'll narrow down this a little bit more and speak only about training, because that's what I work on. So how training is impactful is, when we talk about immunization, we have about 250,000 vaccinators in India who are providing the immunization services. And in the recent years, we've had a lot of changes in guidelines. We've had new vaccine introductions. And the way that they are usually trained is a cascade training model, where there's a national training, and then there's a state training, there's a district level training, sub-district training. So to train such a huge workforce and to ensure that the training content and the training delivery is consistent is quite challenging. And there was a lot of conversation about how there is migration of the health workers as well. So what happens when a health worker from one particular region moves to another and maybe now needs to immunize for a disease that she was earlier probably not doing in her previous district. So training really helps in first of all filling those knowledge gaps. Doing it in a very consistent manner is what we've been aiming to do. So we basically have worked on e-learning courses that are kind of disseminated through a mobile learning app. And we also heard a little bit about COVID and continuous learning. So I think that's also something that's been very helpful for the vaccinators who we've been working with, because they have a lot of flexibility in how they access and go through these self-paced learning courses. So even during COVID, and coincidentally, though it was not planned that way, but our real implementation began in March of 2020. So, that's a time when all classroom trainings came to a standstill. So that continuous learning is something so very important in terms of their capacity building as well. And I think that's something that we've been trying to address, and we have been able to address as well. And similarly, when we talk about zero dose, I think the kind of training methodology that we're using will be very helpful, because the idea of zero dose is a little different here, because we have birth doses, so to speak, right? So it's something that's new. It's something that vaccinators will have to understand. So again, the kind of training approach that we have, I think that will be very helpful in giving them that knowledge in a very consistent manner, bringing global, concepts to them through our training methodologies. So that's how I think it'll be very helpful, Liz.
Great, thanks, Sohini. Appreciate sharing a little bit more about the training that you work on. I'm just curious, in terms of what was presented earlier today, is there any kind of similarities or differences between the approach that you and your team are taking in India and maybe what's been done in Nigeria?
Well, actually, there are a lot of similarities for any capacity building intervention. Even if we are covering only training, I think the first similarity that I saw was there was a very detailed capacity building needs assessment that was done both in Nigeria, and that's something that we've done as well. We also looked at a lot of issues like what are the logistical challenges faced during trainings, what is the kind of daily life of these healthcare workers, what are the services they're providing, which is where we thought that it has to be a very flexible learning. We looked at knowledge and skill gaps as well, and I think, like Jenny mentioned earlier, it's a little bit of a Pareto. So we did not want to kind of digitize the end-to-end of immunization training, but we took concepts that 80% of the 20% of the concepts, you could say, that would lead to 80% of the impact in terms of their service delivery. So I think one similarity was the capacity building needs assessment. Another similarity I saw was there was a talk of dashboards, and how there was this 5-point system that was devised, how there was a lot of tracking done, monitoring done. We too have dashboards. We basically use a mobile application, which is a learning management system. The only difference is that we are tracking only the training performance here. So we are only tracking if a vaccinator is logging in, taking their courses, if they're completing their courses, if they're scoring, a certain a number of scores, if they're getting certified. Similarity in terms of, how do we motivate? The motivation model could be different, but the importance of motivation, I think, is recognized both in Nigeria and in India. So yes, I think a lot of similarities between the basic concepts of what has been done in Nigeria and what our training program is trying to do here in India as well.
Great, thanks again, Sohini. And I know others have been kind of sharing their experiences as well in the chat, so appreciate everyone's participation there. Before I open it back to the audience, I want to circle back to Jenny, and this is actually a question that kind of came up in the chat already. Just based on your extensive experience, what strategies or approaches would you advise stakeholders in low and middle income countries to adopt to establish enduring capacity building programs that incorporate learning by doing? So I know that there were some questions around sustainability and making sure that these approaches continue on. So if you could share maybe a little bit more about that, that would be great. Thank you.
Yeah, well, I think number one, it's making sure that you're working closely with the leaders and managers. And there's lots of different strategies that work well in urban versus rural. So you have to really tailor what's the best for those locations. But I would say that peer learning is a really powerful tool, especially now that digital peer learning is very possible. This is something that I think the immunization world has not really fully explored. And if we can combine peer learning with sort of that connection to the health systems and the organizational structures with what the leaders and managers are doing, I think that would be a really good at-scale efficient and affordable model. Because I don't think, like Sohini pointed out, there's a lot of e-learning courses. This physical training model, while we do need that, it's very important, it's very expensive. And I think if you want government funded training, because now you have lots and lots of training that's externally funded, but if you want government to fund its capacity development approaches, then we need to really focus on what is affordable, what is doable, and what is agile enough to scale in that context of limited resources.
Great. Thank you so much, Jenny. And yes, just a note for someone in the chat mentioned, will the session today be shared out? And yes, it will be. We'll share today's recording slides and then any resources that our speakers mentioned as well through that Boost Bright Spots Learning group. So I want to go back to a couple questions that we received actually during the presentations. So one was around if anyone has experience in application of performance-based incentive mechanisms, noting that staff turnover in countries, especially migration to urban areas, is a big challenge. And was just wondering if any of our panelists or perhaps previous speakers could address that.
Well, I can answer a little bit of that, which is I've seen a lot of programs where you have incentives or top up on salaries for rural remote locations. And there's a lot of other incentive schemes. But again, I would say all of the examples I've seen have been externally funded. I have not seen any incentive scheme that, at least financial incentive scheme, that is government funded. But if there are examples, I would love to hear about those. I think also the intrinsic motivation and the intrinsic incentives are also important. And that's something that Amina highlighted was a key part of the recognition process for the Nigeria model.
Great, thanks for sharing. Anyone else before I move on to the next question?
Liz, I can just chime in here, which is not the incentive of the healthcare workers, but in our program we have some kind of sustainability that the training that we run in order to orient these vaccinators on our app. In a lot of the states, that's being taken care of the government's training budget. So we are not, the ones who are funding those orientation training sessions. So that's one thing. And like Jenny said, the intrinsic motivation, I think that's also being done beautifully by some of the state governments who are, felicitating good learners, felicitating whole districts who are completing their courses quickly. So yeah, that's one perspective from here.
Great, thank you for sharing. It looks like we have a hand raised in the audience. I don't know if Adefunke, you had either a question or comment for our panelists.
Hello.
And if so,
Thank you so much, Elizabeth. I really want to commend all the panelists. This is a very great job, and which everyone had learned, all the immunization champions. So thank you so much. But my question goes to Dr. Kumar from UB. I would like to ask, through the building of the capacity building, there is this the tax shifting, tax sharing, the TSS policy. How are you able to cope with the policy as regards to the who to train among the healthcare worker? Because I know there are usually a problem when it comes to develop or building the capacity training, especially in our settings in Nigeria. I'm also I'm formerly the state monitoring and evaluation officer. I'm a medical practitioner with 15 years of experience before I left for abroad. So please, can you shed the light on probably the challenges you have as per that TSS, TSH? Because I was one of those people that really developed the policy. Is there any challenge as per who to train among the healthcare worker? Thank you.
Yeah, so thank you very much for that question. I think it's very understood. In fact, particularly here in Damaturu, where you have adequacy of skilled manpower, which I'm happy to note, that as far back as 2014, 15, when the state actually adopted and developed tax shifting policy, cut across all the cadres. I think during the conduct that all the cadres were invited, they are part and parcel of the adaptation of the tax shifting policy, and all agreed which area, which part of the activity needs to be taxed. And we all know that at the level of primary healthcare centers, level of care, what we needed is somebody who can provide injection, especially routine immunization. By the previous cadre, the minimum person is somebody with certificates in community health services. And also we also have recognized that there are other cadres within that same cadre, like environmental health officers with they have been trained the same period. So some of these injection components have been restricted to them to ensure that we have a smooth running. Fortunately, we know the environmental health tend to be of a high number in terms of numeral number of healthcare workers in the state and even across all the LGS. The community health extension workers tend to be of minimum number. So that actually, with that shifting, I think it helped in ensuring that the presence of any of these cadre can be trained to provide that needed support. What we needed more on training is to ensure that we improve on the skill in the conduct of this injection safety, because that is the basic areas that no matter even if you are you are qualified by law to provide injection, but if you don't have the skill, so during the capacity transfer, during the training proper, we emphasize, we really dwell more on that component so that to avoid AEF5, because poor routine immunization antigen have different routes of administration. Some IM, some subcute. So if you don't do the right thing during the capacity building, it affects the outcome of the routine immunization. So by and large, there are challenges, but some of the challenges have already been taken by the management, the government of the state to ensure we minimize that kind of component of clash between different cadres of our healthcare providers. Over.
Thank you
Great,
so
thank you.
much. Thank you, Dr. Omar. I really appreciate it. Thank you so much. Thank you very much.
Great. So I think we're almost at time. I just want to ask one more question. And this came up in the chat around how the LGA strengthening approach has been expanded to primary healthcare more broadly, and even if it's been scaled up for immunization. So I don't know if there could be a few words shared there. I think this kind of integration and scale up has been asked a couple times in the chat.
I think Amina can answer that the most. In terms of the shift from RI to PHC MOU basket funds, that's happened in all 6 states. And I know that there was a capacity building effort across all LGAs in the 6 states, but I'm not aware if the specific Yobe intervention was scaled up.
Yeah, maybe I can add to that. Yes, we are trying to scale it up. So we, on our first go around, as we said, we tested the 1LG approach in Damaturu with some success. And with the new support that we're providing to the states, we're trying to trial this in multiple LGAs across the 6 states to replicate what happened in Damaturu, to see the level of success we're able to get and what we'll learn, seeing as they're different LGAs, different states with different contexts, and trying to see what would work versus not. So yes, there's some effort to try to scale that. And as we implement and learn more, we'll be sharing as well. Thank you.
Great, thank you. So I know we just have 1 minute left, so I just want to thank all of our panelists and speakers for today, and hand things over to my colleague Aisha, who's going to talk about next steps. Over to you.
Thanks so much, Liz. And yeah, I just want to also echo the thank you to our guest speakers and panelists. If we can get that final slide up. Okay, just a quick few additional reminders. Please remember to join the Boost community to access the session recording and slides, which will be available by the end of the week. We encourage you all to continue conversations and asking questions on the Bright Spots Learning Group forum. Please remember to also take the post-session survey, which will pop up on your screen after the close of the session. And we will also be sharing out the Boost annual survey. Your feedback is incredibly important to us, and we'd appreciate if you fill out the survey just to help us improve our offerings further. Finally, we hope to see you in 2 weeks for the final session of this 3-part series on March 14th. at the same time for our next session on utilizing community resources for driving immunization and primary healthcare service demand. Thank you again to all of our speakers and participants for your engagement throughout the session. I hope you all have a wonderful week.